Welcome to this special edition documentary feature, coming to you from my office. I'm Dr. Emma Blake, and today we are going on a deep dive into one of the most important and often misunderstood areas of men's health, the prostate gland. Many men, as they enter their 50s and beyond, begin to experience changes in their urinary function. And the first question that naturally arises, is this cancer? It is a fear that is entirely understandable. But it is also a question that has two very different answers, leading us to the heart of today's topic, the critical, life-altering distinction between benign prostatic hyperplasia, or BPH, and prostate cancer. We need to explore both of these conditions, not to cause alarm, but to provide clarity and knowledge, because understanding the difference between a common, non-cancerous inconvenience and a serious malignancy is truly essential for informed decision-making about your health and your future. To begin this journey, we must first truly understand the tiny but powerful gland at the center of this conversation, the prostate itself. The prostate is a small, walnut-sized gland, a vital component of the male reproductive system, sitting low in the pelvis, just beneath the bladder and wrapping around the very first part of the urethra. Think of it as a small toll booth on a major highway. And that highway is the urethra, the tube that carries urine from the bladder, through the penis, and out of the body during urination, and semen during ejaculation. The primary job of the prostate is not urination at all, but rather, to produce prostatic fluid, which makes up a significant part of semen, providing essential nutrients and mobility for sperm. Structurally, this small gland is a complex factory, made up of secretory glands, ducts, and what we call stroma, a surrounding fibrous muscular tissue that provides support and structure. It is this intricate architecture, this specific positioning relative to the bladder and the urethra, that explains why problems in this little gland can have such a profound effect on a man's quality of life. The prostate is not uniform. It is functionally and anatomically divided into several distinct zones. And recognizing these zones is perhaps the most crucial element in differentiating BPH from prostate cancer. The three main functional zones are the transition zone, the central zone, and the peripheral zone. The transition zone is the small, inner area, the part that directly surrounds the urethra as it exits the bladder. The peripheral zone is the much larger outer part of the gland, often referred to as the back or the rim of the prostate, lying closest to the rectum. Finally, the central zone is wedged in between these two. Why do we focus on zones? Because the fundamental structural difference between BPH and prostate cancer lies in where they begin and how they decide to grow. BPH, the benign enlargement, almost exclusively originates in the transition zone, the area right next to the urethra, the toll booth. Prostate cancer, on the other hand, is overwhelmingly and most commonly found in the peripheral zone, the outer rim of the gland. This means they are fundamentally two separate disease processes, occurring in two different compartments. One is an internal plumbing issue, and the other is a concern on the outer perimeter. Let's explore what fuels this growth, because both conditions are inextricably linked to hormones, particularly the male sex hormone, testosterone, and its more potent derivative, dihydrotestosterone, or DHT. Throughout a man's life, testosterone is the main driver of prostate growth and development. But inside the prostate's stromal cells, there is a special enzyme, called 5-alpha reductase, which acts like a molecular converter. This enzyme transforms testosterone into the supercharged hormone, dihydrotestosterone. DHT is incredibly powerful. It binds to receptors on the stromal cells, causing them to release growth factors and signaling molecules that stimulate cell division and growth throughout the prostatic tissue. This is a normal, healthy process during development. But as men age, this delicate hormonal balance begins to shift. With the passage of time, circulating levels of testosterone naturally start to decline, while estrogen levels may rise relatively, and crucially, DHT continues to accumulate within the prostate cells. This shifting hormonal landscape seems to act as the primary catalyst, the trigger for excessive cell proliferation that characterizes both BPH and, ultimately, prostate cancer. But the way they proliferate is where the two conditions dramatically diverge, and this returns us to our zonal map, the transition zone versus the peripheral zone. Let's focus first on benign prostatic hyperplasia, BPH. The word benign is our most important descriptor here, meaning it is non-cancerous, it does not spread, and it does not kill. BPH is essentially a form of overgrowth, a non-malignant expansion, primarily driven by the accumulation of those epithelial and stromal cells, the glandular and connective tissues, but specifically within the transition zone of the prostate. As these cells multiply, they cluster together and form small, dense, benign nodules. Imagine small, soft tumors, but benign ones. Over the course of many years, these nodules slowly coalesce and expand, causing the inner part of the prostate to swell, like a slowly expanding donut around the central pipe. This is the enlarged prostate that we hear so much about, because this growth happens right around the urethra, the inner pipe. The physical consequence is compression. The enlarging tissue acts like a clamp, squeezing the urethra and literally blocking the outflow of urine. This is a purely mechanical, obstructive problem. And this is why BPH leads to those characteristic urinary symptoms we group together as lower urinary tract symptoms, or LUTS. The symptoms are essentially a cry for help from the bladder, struggling against the blocked exit gate, leading to a weak or interrupted urine stream. The feeling of incomplete bladder emptying, having to strain to start urination, and the annoying, disruptive need to wake up frequently at night to urinate, a condition we call nocturia. These symptoms, while frustrating and severely impacting quality of life, are the direct result of a mechanical squeeze, an expanding but perfectly contained, benign growth. Now, we must turn our attention to the more serious condition, prostate cancer. This is not a mechanical overgrowth. This is a true malignancy, an uncontrolled and invasive cellular process. Unlike BPH, which is focused on the inner transition zone, prostate cancer is found in approximately 70 to 80% of cases in the larger, outer rim, the peripheral zone. Here, the origin story is different. It is not simply about excessive cell growth. It is about genetic mutation and cellular anarchy. The glandular epithelial cells in the peripheral zone undergo mutations that allow them to ignore the body's natural signals to stop dividing, and they begin to replicate in an uncontrolled, chaotic, and aggressive manner. This leads to the development of new, abnormal glands, and the formation of one or more true malignant tumors. The nature of this growth is the key difference. It is not just expansive, like a balloon, it is invasive. These malignant cells actively push into and destroy the surrounding healthy tissue, and as the tumor grows larger, it too can potentially compress the urethra, leading to similar obstructive urinary symptoms as BPH, or it can grow outwardly, silently, towards the capsule of the prostate. And it is this invasive nature that introduces the most frightening word associated with cancer, metastasis. Unlike benign BPH, which always remains confined to the prostate cancer cells have the capacity to break away from the primary tumor and spread. They can travel through the lymphatic system or the bloodstream to establish new malignant colonies, or metastases, in distant parts of the body. The most common site for this distant spread is the bone, which can unfortunately lead to debilitating pain and other complications. This ability to spread is the defining feature that elevates prostate cancer from a local growth problem to a life-threatening systemic disease, a profound difference from the contained, non-lethal nature of BPH. So, how do we, as clinicians, begin to tell the difference between these two conditions, especially since they can, sometimes, present with frustratingly similar symptoms? The process begins with vigilance and screening. The two main screening tools are the digital rectal exam, or DRE, and the prostate-specific antigen blood test, the PSA test. The DRE is a quick physical examination, where a doctor inserts a gloved finger into the rectum to feel the back surface of the prostate. Why the back surface? Because, as we've established, the majority of prostate cancers are found in the peripheral zone, the outer rim, which is directly accessible and palpable during this exam. A doctor is feeling for any hard, lumpy, or asymmetric areas, signs that could indicate a cancerous nodule. Since BPH is an inner transition zone expansion, it often feels smooth and symmetrically enlarged. Next, We have the PSA blood test. PSA is a protein produced by both normal and malignant prostate cells, and the test measures the concentration of this protein in the blood. Now this is where the waters can get a little muddy, and it is a point of confusion for many men. A high PSA level does not automatically mean you have cancer. BPH, that non-cancerous enlargement, can also significantly raise your PSA, because a larger gland simply produces more protein. Prostatitis, or inflammation of the prostate, can also cause a huge spike. This is why the PSA is a screening tool, not a diagnostic one. It tells us that something is going on with the prostate, but it doesn't tell us what. It simply flags the need for further, more sophisticated investigation, such as an MRI, or ultimately a biopsy, which remains the only way to definitively diagnose prostate cancer and determine its grade and aggressiveness. When we have a diagnosis, the treatment paths diverge entirely, reflecting the distinct nature of the diseases. One we seek to manage for comfort, and the other we seek to eradicate for survival. For benign prostatic hyperplasia, BPH, the treatment philosophy centers on symptom relief and shrinking the gland. For men with mild symptoms, we often start with what we call watchful waiting, simply monitoring the situation with regular checkups. When symptoms become bothersome, we turn to medications. The first line of defense is often a class of drugs called alpha blockers. These medications don't shrink the prostate. Instead, they work by relaxing the smooth muscles in the prostate and the neck of the bladder, effectively widening that compressed urethra, allowing urine to flow more freely. They are designed for quick symptomatic relief. The second major class of BPH medications are the 5-alpha reductase inhibitors. We met 5-alpha reductase already. It's the enzyme that makes DHT. These drugs block that conversion, thereby reducing the amount of powerful DHT acting on the prostate cells. As a result, the hormonal fuel for the excessive growth is cut off, and the prostate gland actually shrinks over time, which can take months, but can provide substantial long-term relief and reduce the risk of needing surgery later. If medications fail to provide adequate relief, or if the BPH is causing complications like recurrent infections or bladder stones, then a surgical intervention may be necessary. The most common surgical procedure for BPH remains the transurethral resection of the prostate, or TURP, where the urologist uses a scope to shave away the excess prostate tissue that is blocking the urethra, essentially widening that central pipe again. Newer, minimally invasive options, like laser procedures or the UroLift system, which uses small implants to physically hold the enlarged tissue away from the urethra, are also increasingly popular, all aiming to resolve that central mechanical obstruction. The treatment landscape for prostate cancer, however, is far more complex and far more aggressive, reflecting the seriousness of a malignant tumor. The first and most critical step is risk assessment, as prostate cancer can range from very slow-growing, indolent tumors to highly aggressive forms. For men with very low-risk cancer, sometimes the best course is active surveillance, which means closely monitoring the cancer with regular PSA tests, DREs, and sometimes repeat biopsies or MRIs. The goal is to avoid or delay unnecessary treatment and its potential side effects, while maintaining the readiness to intervene if the cancer shows any sign of progression. For cancers that are higher risk, or have begun to progress, the mainstay of curative treatment includes surgical removal of the entire prostate gland, a procedure known as radical prostatectomy, or various forms of radiation therapy. Radical prostatectomy, particularly when performed robotically, is a highly effective way to remove the cancer entirely, along with the prostate and sometimes the nearby seminal vesicles and lymph nodes. Radiation therapy, delivered either externally or internally via seed implants, is another highly curative option, aimed at destroying the cancer cells while preserving surrounding healthy tissue as much as possible. Beyond these local treatments, systemic therapies are crucial for more advanced or metastatic disease. Hormone therapy, specifically androgen deprivation therapy, is a primary strategy. This treatment works by cutting off the cancer cell's supply of testosterone, the very fuel we discussed earlier. Without testosterone, the cancer cells often stop growing or even shrink. Finally, for widespread or very aggressive cancers that no longer respond to hormone therapy, chemotherapy or newer targeted therapies may be employed to attack the cancer cells throughout the body. But the primary goal, especially for localized disease, is always cure and cancer control. In the end, what we have explored today are two entirely different diseases that happen to occur in the same place. The prostate, BPH, is a benign, growth-related disease of the inner transition zone that causes physical, mechanical obstruction, primarily managed for comfort and quality of life. Prostate cancer is a malignant, invasive disease of the outer peripheral zone that carries the risk of metastasis, primarily managed for cure and survival. The common thread is age, and the resulting shift in male hormones. But the biological mechanism, the anatomical location, and the ultimate outcome are worlds apart. This is why awareness and open conversation with your doctor is your greatest tool. If you are experiencing changes in your urinary stream, please do not dismiss them as just getting older. Talk to your physician. Have that important conversation about the DRE, about your PSA levels, and about the screening guidelines that are right for you. Early detection and accurate diagnosis are not just medical advice. They are truly empowering acts of self-care. Thank you for joining me on this essential health deep dive.